when you see this ultrasound picture, you are able to see they have measured the endometrial thickness, okay, from here to here, right? And it is mentioned as 1.82 centimeter, which is approximately 18 millimeter, right? So there is diffuse myometrial thickening seen with the junctional zone thickness, which is about 18 millimeter. As well as, I don't know if you are able to appreciate in the screen, but yeah, you are able to see some small cyst also here, okay? And this is another picture where you are able to see regions of acoustic shadowing which are much parallel to each other, right? So this is a Venetian blind appearance of adenomyosis. Are you clear? Right. Now comes your favorite image. So this is going to be a, yes, chocolate cyst, right? So what is a chocolate cyst? It is basically an endometrioma, endometriosis that has occurred in the ovary, right? Yes. Now when you see the ultrasonogram, you are able to see there is homogeneous echogenic content, okay, as well as you are able to appreciate some dark region below that. So this is the pelvis region and you have some free fluid over here, okay. So basically there is homogeneous echogenic content plus free fluid in the pelvis, okay. So this is endometriosis. Now let's discuss something about endometriosis. Sites of endometriosis. So what are the important sites of endometriosis? So endometriosis common site is going to be pelvis, okay, and in the pelvis, yes, ovaries are going to be the most common site, but it can also occur in the tubes or the pouch of Douglas or even your uterosacral ligaments or your broad ligaments or even your round ligaments, right? And extrapelvic site is also possible. It can happen in the GIT where it will occur commonly, and that is the most common extrapelvic site is GIT. Then it can happen in the urinary tract or umbilicus or even scar, okay. So the only extrapelvic site that is not reported so far is the spleen, right? Otherwise all the other extrapelvic sites have been reported. Now let's talk about chocolate cyst in specific. So this is also known as endometrioma or cystic ovarian endometriosis, okay. So what you are able to see here, you are able to see a thick, viscous, dark brown fluid that is composed of hemosiderin of old blood, okay. Mostly endometriosis or endometrioma is seen in the reproductive age group, and the classic triad of symptoms which these patients will be presenting will be dysmenorrhea, dyspareunia, as well as infertility, okay. So this is the classic triad of symptoms, and dyspareunia is seen mostly with deep endometriosis lesions. Deep endometriosis lesions means when the lesions are going to be more than 5 millimeter in depth, okay. So how will you manage an endometrioma? So management of an endometrioma, when the cyst size is going to be more than 3 centimeter, you will offer her total ovarian cystectomy, right? And in smaller cyst, and if she is symptomatic, you will offer aspiration of the contents. Then you will also do an ablation of the cyst capsule. Clear? Right. Now let's see this image. I don't think this needs any introduction, right? Yes, this is going to be a leiomyoma. Okay. Now let's talk about the gross picture first. So you are able to see a leiomyoma, and this can be any shape, right? You are able to see multiple leiomyomas, but yeah, a single leiomyoma is also possible. So it can be single or multiple. And the shapes also, see, this is a complete round leiomyoma, but this seems somewhat oval, right? So the shape can be round or oval as well. And usually they are of film consistency. Okay, the consistency is going to be film, and they can be softer also when the degenerative changes are seen. Okay, and usually if you take a fibroid, a separate fibroid, it is usually covered by a pseudocapsule like this. Okay, so what does the pseudocapsule means? This pseudocapsule is a connective tissue layer that will be separating the leiomyoma from the surrounding myometrium. Okay, and this becomes the plane of cleavage when you offer a myomectomy to a patient. Clear? Right. Now let's also discuss about the microscopic picture. You will be able to see smooth muscles in a rolled pattern of arrangement. Okay, you see a rolled pattern of arrangement of smooth muscles over here, and there will be interlacing fascicles. Okay, so basically these smooth muscle cells are going to be spindle shaped. Okay, and remember, each myoma is developing from a single smooth muscle cell. Okay, right. Now if we see the clinical features, 50% of them are going to be asymptomatic only, and the rest of the 50% can present with any symptoms, like they can present with heavy menstrual bleeding or intermenstrual bleeding. There can be dysmenorrhea or dyspareunia, and sometimes pelvic pressure symptoms can also be there. Some can even present with infertility. Clear? So these leiomyomas are further subclassified into the following types. There is a subclassification system for leiomyoma where it will be submucous leiomyoma, and you have other types of leiomyoma that is represented by the letter O. Submucous leiomyoma is represented by the letter S. Because why the submucous leiomyoma has this importance means this is the most common type of leiomyoma that is going to cause infertility, right? So you have to see, this is not at all tough. What you have to do is you have to just start from the cavity of the uterus, and one by one you have to move it and take it to the outside. Okay, so that is how it moves. Okay, so first one is a penetrated intracavitary leiomyoma, that is type 0. You have to start from 0 to 8. That is also important, right? Then first type is less than 50% intramural. Okay, so the most of them are inside the cavity, so it becomes less than 50% intramural. Then it goes more intramural, so it becomes more than 50% intramural. Then next type is completely intramural, but it is also touching the endometrium, right? Then it becomes a complete intramural, there is no contact with the endometrium. Then it moves slowly towards the subserous side, but more than 50% is going to stay intramurally only. Then it becomes subserous one, but there is only less than 50% intramural. Then it becomes a subserous pedunculated type, and finally it will become a cervical leiomyoma or a parasitic leiomyoma. That is the pedunculated one. The pedicle will get cut and it may become a parasitic leiomyoma, and also the other type will also include your cervical leiomyoma. Clear? Right. So this is about the leiomyoma subclassification system. Okay. So far questions have not been asked on this, but I want you to know. Okay. Right. Now let's discuss some of the complications that are seen with leiomyoma. I told you the patient will be presenting with heavy menstrual bleeding, intermenstrual bleeding, and so many AUB complaints. So definitely the patient will be having anemia, and there are so many types of degenerative changes that will include your hyaline degeneration, red degeneration, cystic degeneration, etc. Okay, and a pedunculated fibroid especially can go for torsion also. This is mostly seen with a subserosal pedunculated fibroid. Then in puerperium there is a chance of infection also. Okay, and mostly leiomyomas or benign tumors, but they can also become malignant, where they will be known as Leiomyosarcoma. Clear? Right. Now, yeah, this picture, what do you think this is? Definitely this is going to be a leiomyoma, right? Okay, but you see something very furious here. That is, the leiomyoma is very furious. It looks somewhat red. Yes, it is going to be a red degeneration. And see, you are able to make out the soft structure also, right? It seems to be like a soft structure. So it is a red degeneration of leiomyoma. Okay, so this is mostly seen during pregnancy because of the increased vascularity in pregnancy. This happens. There is increase in size of the fibroid, as well as it becomes soft as well. Okay, and the presenting complaints of the patients will be, she will be complaining of fever, and when you take a CBC there will be leukocytosis. Obviously pain can also be there. Okay, so what is happening here means there is hemorrhagic infarction. So that is causing the pain. So the pain will be acute pain and it will be focal in site. Okay, right. So what do you want to do to this patient? You will treat this patient by offering her bed rest, analgesics and antibiotics. Clear? Right. Now, sometimes they can give you a similar scenario and tell she is a pregnant female only. Okay, a pregnant female who is in her second trimester came with acute abdominal pain, but there was absence of fever, and while I investigated there was no leukocytosis. This means clearly the patient is not going to have a red degeneration, right? So what do you suspect in this patient? Yes, the patient is a known case of fibroid that I forgot to tell. Then it might have been a subserous pedunculated fibroid which has undergone a torsion. A torsion can also produce acute abdominal pain. That's what I want you to know, right? Yes. Now, so management of fibroid, you will treat her symptomatically, you will give a option of myomectomy or hysterectomy depending upon the age parity. That is a different topic of discussion and it is very detailed also. I am not going to take that much detail now. I want you to know when you want to offer treatment when the patient is asymptomatic. The patient is asymptomatic, 50% of them are asymptomatic, right? Still you want to treat the patient. So what are the conditions for that? So the indications of treatment in an asymptomatic fibroid. So this will include, first let us see the size. when the size of the fibroid is more than 12 weeks in size, or as we have seen, there is a risk of torsion, that is when it is a peduncle fibroid, or it is a rapidly growing fibroid. So, you suspect malignancy. Then when the patient presents with infertility, okay, for example, if it is a submucous fibroid which will cause recurrent pregnancy loss, or it can be a cornual fibroid also that can cause tubal block like that. And finally, a fibroid that will cause pressure symptoms, okay, and especially when the pressure symptoms are caused on the ureter or bladder, the adjacent urinary tract, it will result in urinary tract infection, okay, and even sometimes urinary retention. So, when the patient presents with any of these symptoms, okay, then even in an asymptomatic patient, okay, because of the fibroid the patient is not having any complaint, but even then you have to treat them, okay. I accept this is a symptom, but in these cases you have to treat the patient, correct? Yes. Now, let us go to the next one where you are able to see this picture. I hope you would have all guessed, right? So, what is this? This is a PCOD, right? Polycystic ovarian disease. You are able to see so many cysts in both the ovaries, okay. They have mentioned the number also, like 1 to 10 cysts here, and here 1 to 5 in the anterior region itself. We don't know how much is present in the other side, okay. So, you are able to see moderately enlarged ovaries, right. So, these are moderately enlarged ovaries. You have multiple follicles, and see the follicle size is somewhat smaller only, it is not that big, right. So, you have multiple small follicles, and mostly these follicles are of uniform size that will be arranged circumferentially, okay, in the subcapsular region, okay. The volume will also be more, okay. So, this is the interpretation of this ultrasonogram, and we came out with the diagnosis also. Now, so this is another form of PCOD presentation where you are able to see the cysts are beautifully arranged in the subcapsular region like this, and this appearance is called as, yes, string of pearl sign, okay. Suppose if they tell you, they don't give the image, but they tell string of pearl appearance seen on ultrasonogram, that means they are referring to PCOD, okay. So, let us discuss about the syndrome, that is polycystic ovarian syndrome, okay. So, on ultrasonogram you will be able to see more than or equal to 12 antral follicles in either ovary, okay, not necessarily in both ovaries, in either ovary if you see, that is enough, and the antral follicle size can be anywhere between 2 to 9 millimeter, and there can be increased ovarian volume as well, that will be more than 10 millimeter cube, okay. And the next one is, you will be able to see clinical or biochemical signs of hyperandrogenism. Then you will have chronic anovulation. Okay, that will be evident by oligomenorrhea or amenorrhea. So these 3 points are different. Okay, the first one is a ultrasonogram picture and the next one is the clinical picture. Okay, so all these 3 together will constitute the Rotterdam criteria of PCOD. Right? Now, one more thing I want you to tell us about the hormone profile in these patients. There is increased luteinizing hormone, but remember there is a normal follicle stimulating hormone. Okay, so seeing so many follicles, you will immediately think the follicle stimulating hormone is going to be high, but it's not like that. Luteinizing hormone is high and there is normal follicle stimulating hormone. Clear? And next, there is increased luteinizing hormone follicle stimulating hormone ratio where it will be more than 2:1. Androgens are increased. The total testosterone is going to be high, but definitely they are not going to be more than 200 nanogram per deciliter. Okay, so they will be less than 200 nanogram per deciliter, and if they are more than 200 nanogram per deciliter, then you have to immediately think about ovarian carcinoma. Okay, if they are still higher, say they are more than 700 nanogram per deciliter, then you will think about some adrenal tumor. Okay, these patients will also have an abnormal OGTT or lipid profile, and there will also be increased levels of prolactin in them. Clear? So this is the thing. Okay, and management of these patients, the first line of management you will offer them is lifestyle modification. Okay, so diet changes, routine exercise should be offered like that. Okay, then if they present with infertility, you can offer them ovulation, induction, and finally you can offer them surgical option also with laparoscopic ovarian drilling. Okay, then you have to manage their lipid profiles and their abnormal OGTT and all. Okay, that is a different part of story. Right, now what I want you to know is you never offer surgical management as a first option to this patient. Okay, so lifestyle modification is the first line management of the patients with PCOD. That one you have to know. Clear? Right. Now, there is a syndrome called as hair and syndrome. Okay, so the components are hyperandrogenism, insulin resistance, and acanthosis nigricans. Okay, all these features are seen in PCOD also. Okay, so yeah, now this patient, what are you able to see? You are able to see excessive hair growth in this female, right? So that is going to be hirsutism, right? Now let us discuss what is hirsutism. Okay, so hirsutism is the presence of prominent facial and body hair. Okay, so that means the villous hair that is seen all over the body in the female is converted into terminal hair. Okay, due to increased androgen, these changes are seen. The common cause of hirsutism is, just now we have discussed, it is going to be, yes, PCOS in 70 to 80% of the cases. Okay, There are so many causes, like it can be due to congenital adrenal hyperplasia or tumor or drugs or anything. And yeah, of course, idiopathic also in some cases. Okay. Now, I want you to know the difference between hirsutism and virilization. Okay. So, virilization. Virilization means the excessive changes that are happening in the female body that will be tuning them more like a male, okay, due to excessive androgens. And in that, hirsutism is going to be a component, right? Yes. In virilization, hirsutism is a component. Also, they will have acne, amenorrhea, there will be breast atrophy, there will be enlarged clitoris. So, clitoromegaly means the size is more than 10 mm by length, and it is going to be 7 mm, more than 7 mm at its proximity. Okay. These patients will also have deep voice and androgenic alopecia. Okay. So, these are the features of virilization. Okay. Hirsutism is a component of virilization. Clear? Right. Now, the scoring system which you will offer for hirsutism is your Ferryman Galway scoring system. Okay. So, here we are going to check 9 regions in the body and we are going to give a score. Okay. So, that is not important in that detail, you just know the scoring name alone, right. Now, how will you treat this patient? You will treat them by offering oral contraceptive pills, anti-androgens. Okay. So, there are so many anti-androgens, like you can offer them spironolactone, cyproterone acetate, flutamide or finasteride, and you can offer them topical drug also, that is eflornithine hydrochloride. Clear? So, this is all about hirsutism, right. Now, yeah. Now, seeing this pic, don't tell me this is PCOS, okay. So, the difference between PCOS and this pic is that here you are able to see many big cysts, right, many big cysts, and they are of varying sizes also, right, and they give you a clinical scenario telling a young female 26-year-old who was taking treatment for infertility by ovulation induction presented with this image, and she is also complaining of difficulty in breathing. Now come to the diagnosis. Yes, this is going to be a ovulation hyperstimulation syndrome, right. So, this is going to be a OHSS. Now, the ultrasound pictures are showing, usually there will be symmetric enlargement of both the ovaries. Okay, in PCOS we saw it is going to be either of the ovary, and the size is more than 12 centimeter, and you will be seeing multiple cysts that will be giving a characteristic spoke wheel appearance. Okay, so they show a classic spoke wheel appearance, and there will be associated ascites plus pleural or pericardial effusion. Okay, so that's fine. In the case scenario, I told you the patient had difficulty in breathing. Okay, and this pleural or pericardial effusion is happening due to capillary leak. Right? Yes. So this is the ultrasound picture. Now let me talk about OHSS in short. So this is a complication of controlled ovarian stimulation that is done by in vitro fertilization, and you will be able to see ovarian enlargement and accumulation of fluid in various regions. So the patient will also have, apart from pleural effusion, ascites, whatever, the patient will also have weight gain, then intravascular volume depletion as well as oliguria. Clear? Right. I am not going into the treatment, management, everything. Okay, then the session will be very lengthy. Okay, yeah. And let's talk about this picture. So here also you are able to see so many cysts. Okay, and another differential diagnosis you have to keep is your thecal lutein cyst. Okay, these are your thecal lutein cysts. So thecal lutein cysts are seen in such a way whenever the patient is suffering from a condition where there is secretion of excessive human chorionic gonadotropin hormone. For example, in conditions like gestational trophoblastic disease or multiple pregnancy, okay, like that. Even in your OHS, she can have this. So these are large sized cysts. In USG, you will be able to see multi-loculated cyst, and in gross appearance, okay, so this is a gross appearance where you are able to see smooth, yellow and lobulated cyst, and most of them are with thin walls. Okay, they are with thin walls. Okay, and these patients are usually asymptomatic, and they go for spontaneous regression as well. Okay, rarely, very rarely they can go in for a torsion, so that may necessitate surgery. Clear? Right. We have discussed so many types of ovarian cysts now, and we have to know that ovarian cysts are always not benign. There can be malignant cyst as well. So to differentiate between benign cyst and ovarian cyst, there is a special criteria called as IOTA criteria. Okay. Now, this is nothing but International Ovarian Tumor Analysis criteria. Okay, so let's discuss this. We will have the benign features as well as the malignant features. Okay, so let's discuss the benign features first, so that you will be able to come up with the malignant features by yourself, right? So benign features, these are unilocular cyst usually. There is presence of solid components. Okay, it's not completely absence of solid components. Solid components can be present, but the size is going to be less, that is less than 7 millimeter. Then there is presence of acoustic shadow. There will be a multilocular tumor as well, which will be smooth, and the maximum diameter of such tumor will be less than 10 centimeter, and finally there will be no blood flow. Okay, so that means it is a benign cyst, whereas in a malignant cyst it is going to be completely opposite, right? So these cysts these malignant masses that you see in the ovary are going to be irregular and more or less they are going to be solid, okay, more solid, okay. There will be presence of ascites as well as, instead of acoustic shadows, there will be presence of papillary structures, and there will be at least 4 papillary structures present, and these are irregular multilocular tumor. Definitely the size is going to be more than 10 centimeter, and there is color Doppler will be showing blood flow, okay, color Doppler should be showing blood flow. That will be a very strong blood flow. Clear? So this is IOTA criteria. So if you see the pic, you will be able to understand. So you have B1, which is a unilocular tumor. There is presence of solid components, but this solid component definitely is not going to exceed 7 millimeters. You have presence of acoustic shadows. There is smooth multilocular tumor, but the size of the whole mass is going to be less than 100 millimeters, and there is no blood flow. That is, they have given only a color score of 1, right? So here in malignant features, we will have an irregular solid tumor. There is presence of ascites. There is at least 4 papillary structures. There is a irregular multilocular tumor whose size is more than 100 millimeters, and there is a very strong blood flow. That is, the blood flow is seen throughout the mass. Okay, that means it is a malignant one. Now, how to manage ovarian cyst in case of premenopausal women and postmenopausal women? That is very important. Okay, so in case of premenopausal women, you have to see whether they have a simple cyst. Okay, so if the cyst size is less than 5 centimeter, then there is no need for follow-up. Suppose the cyst size is between 5 to 7 centimeter, then you have to repeat ultrasonogram, repeat USG every 3 to 4 months, and after this, either the cyst can go for a resolution, that means you can stop follow-up. Suppose the cyst is going to persist and there is an increase in size, or you see M features, what we have mentioned so far, then you will ask them to check their tumor markers. Okay, so this is when you see only a simple cyst with B features. Okay, so this is how you will proceed. Clear? Right. In a premenopausal woman, okay, suppose if the woman is postmenopausal, you have to check something called as risk of malignancy index. Okay, so risk of malignancy index is something which is calculated by using your CA125 score, then your ultrasound features of the cyst, and the menopausal status of the female. Okay, whether she is premenopausal or postmenopausal, like that. Okay, so here CA125 value means you can have the exact value in unit per ml, and ultrasound features of cyst means you have to give her a ultrasound score. Okay, you will be checking features like whether it is a multilocular cyst, or there is presence of solid areas, or there are presence of metastasis, whether they are bilateral lesions, or there is presence of ascites. Okay, so among these features, when you see no suspicious lesions on ultrasonogram, then you will give her a score 0. When you see one suspicious feature, you will offer her a score 1. When you see more than or equal to 2 features, you will offer her 2. When you see more than or equal to 2 features. Clear? And regarding her menopausal status, when she is premenopausal, you will offer her score 1, and when she is postmenopausal, you will offer her score of 3. Clear? So this is how RMA index is calculated, that is risk of malignancy index in ovarian cyst. If the score is less than 25, then the risk for malignancy is low. If it is between 25 to 250, then the risk is said to be moderate, and when it is more than 250, the risk is said to be high. Clear? So this is all about risk of malignancy. So now coming back to the management of ovarian cyst in a postmenopausal female, if the risk of malignancy index is less than 25 and there are no malignant features, there are no M features, what you will do is you will follow up her for 3 to 4 months, and after that either thing can happen. Okay, so it will go for either resolution, or if the cyst persists or increases, or there is any M features, then you will offer her tumor markers and proceed accordingly. Clear? Now, so this is a gross specimen of an ovarian cyst given to you. So what you are able to see here is, you are able to see that the cyst has smooth surface, right? The cyst has smooth surface and it is mostly a unilocular cyst, right? Cut section is not given, but yeah, it may be a unilocular cyst, and definitely the consistency seems to be like a serous fluid, right? So what do you think? This is a, yes, very good. This is a serous cyst adenoma. Okay, a serous cyst adenoma is a most common type of benign ovarian neoplasm. This is bilateral in 20% of the cases. The size is usually moderate, and I have explained already the gross features. On cut section, sometimes you will be able to see large solid projections, okay, or nodules, or even areas of hemorrhage. Then you have to think the chance of malignancy, that is serous cystadenocarcinoma, right? So this is how it will be, okay. And this is the microscopic picture of serous cystadenoma, where you are able to see a ciliated columnar epithelium, okay, and a serous fluid that is present in the lumen, and it is covered by a fibrovascular wall. And one more thing is, it is not shown here, but remember, a serous cystadenoma has something called as sarcoma bodies. Okay, sarcoma bodies are nothing but areas of calcified granuloma, areas of calcified granulation or granuloma, which are the end products of the implants, papillary implants that are seen, right? And these tumors are mostly asymptomatic, and they are mostly found as an incidental finding, and the chance of developing malignancy in these patients is about 25%. Is that clear? Now, this is a cut section picture. You are able to see, yeah, somewhat oily, shiny content. It is a mucinous content, right? So what is this? This is a mucinous cystadenoma, right? Yes. So mucinous cystadenoma on Ross picture will be either round or ovoid in shape. They are surrounded by smooth capsules as well. On cut section, if you see, you are able to see numerous septa that is intervening, right? So on cut section, you are able to see numerous intervening septum, and they contain clear viscid fluid as well. Okay, and remember, this is the second most common benign tumor, which is going to be bilateral in 10 to 15% of the cases, right? So this is the microscopic examination of a mucinous cystadenoma, where you are able to see so many multiloculated cysts, and inside the center pink color area is nothing but the mucin that is secreted by the columnar epithelium, and you will be having goblet cells as well, right? So the goblet cells are the one which are going to secrete the mucin. So there is mucin in the lumen and you have fibrovascular septa. Okay, right. Now coming to your favorite one. So this is a dermoid cyst, right? Okay, so this is a dermoid cyst. It doesn't need any introduction, but you're able to see hair follicles, tooth, bone, and so many types of other tissues. Definitely these are not ovarian tissues, right? Yeah. So a dermoid cyst is nothing but a benign cystic teratoma. Okay. So it is called dermoid because there is presence of dermal elements, and this is the most common variety of germ cell tumor, which constitutes about 95% cases of the germ cell tumor, and 60% of them are benign neoplasms. Okay, the size is usually mild to moderate, and they will show bilaterality in 15 to 25% of the cases, and these tumors are seen in comparingly younger females. Okay, so if you see the gross appearance on a cut section, you are able to see a cyst wall which is mostly white in color. Okay, and that will be a thick cyst wall. Okay, so it will be somewhat thick as well as opaque as well, and you will be able to see a Rokitansky protuberance. Okay, Rokitansky protuberance is nothing but a localized growth that protrudes into the cystic cavity. Okay, and inside the cavity you will be able to see hair follicles, bone, cartilage, and so many types of tissues. Okay, the content can be either ectoderm, endoderm, or mesoderm, but the ectodermal components are most commonly seen. Also, you will have a large amount of greasy fluid inside the cyst. Clear? Right. Now let's see the microscopic examination. You have to know, while you see via microscope, you will be able to see all three germ layer components, and the Rokitansky protuberance will have stratified squamous epithelium that will have sweat glands and sebaceous glands. Okay, there can be chances of torsion also because they will also have a long pedicle. Okay, long pedicle, so chances of torsion are more. While giving a clinical based question, they can just mention on ultrasonogram a tip of iceberg sign seen. Okay, then this is referring to the dermoid cyst only. Okay, you have to know. Okay, so this is formed by amorphous echogenic interfaces in fat or hair and tissues, right? Rokitansky protuberance will be seen as a 2 to 4 centimeter hyperechoic area in an ultrasonogram. So how will you treat them? Yes, definitely you will offer them an ovarian cystectomy. Okay, that can be given by a laparotomy or a laparoscopy also. Clear? Right.